Did not.
Did you also ask her whether she had experienced any auditory hallucinations?
I did.
And did she experience any?
Not at the time, no.
And did she indicate to you whether she'd ever experienced any?
No.
How about visual hallucinations? Did you ask her about those?
I did.
And did she indicate that she had experienced any?
No.
And delusions, did you ask her whether she had any delusions?
I didn't ask specifically about delusions, I believe.
Okay. And in the course of talking with an individual, do you kind of constantly keep that in mind with what they're telling you, whether they're having any ideas of delusion?
Yes, I do.
In the conversation you had with her on November 20th, did you identify, based on your conversation with her, whether she was experiencing delusions?
No, I did not.
And fair to say, a standard set of questions that you also ask have to do with drug use or tobacco or alcohol. Did you ask those questions as well?
I don't recall.
Okay. If I were to show you your note, would that refresh your memory?
I have my notes right here. I could look at it.
Okay. I'm going to draw your attention to the note from November 20th of 2022.
Yes, I did ask her, apparently. And she said no to illicit drug use, tobacco or marijuana or alcohol at that time.
Okay. And she also indicated to you that at this time on November 20th that she had stopped breastfeeding.
That's correct.
Now, did she schedule or did you schedule with her an intake for the next day, November 21st?
We did.
And at the clinic, what generally is the practice for whether a person appears in person or on a telehealth visit or virtually?
Generally speaking, we like to do the intake in person as long as it's feasible. And for her, it was.
Okay. And just kind of while we're on that topic, going forward with a patient who's being seen at the clinic, what are the criteria to determine an in-person visit or a telehealth visit?
They're given the option about what works best for them.
And are there instances where you as a provider might insist a person comes in person?
If somebody needs to do like a urine drug screen or laboratory work, we'll have them come in. Or if they seem to be not making sense or having more difficulties, we'll have them come in person.
And if a person is scheduled for an in-person visit and there are no observed issues on your end, can they opt to change it to a virtual appointment at any point?
Yes.
Okay. And that's just the normal course of business at the clinic?
Correct.
Now, in this particular instance, you said the intake was in person, right?
Yes.
And during the course of the intake, are there particular types of questions that are asked of the person to get to know them and get to know their situation?
Yes, generally we do a full intake. The first thing they do is meet with the nurse who does all the screenings.
Okay. And one of the things that is asked of an individual when they come in is to tell you why they are there, right?
Correct.
What their complaint is.
Yes.
And so for this patient, for Lindsay Clancy, what did she identify as the reason for the visit?
Would it be okay if I refer to my note?
Sure.
So she said pretty much I cannot sleep was her major concern.
Okay. And is that something that you've seen in your experience with new moms that come through the clinic and are postpartum?
It's very typical.
Now, even with that report or that reason, do you do a full history to try to identify kind of what's going on in the present and what has happened in the past?
Yes, I do.
And generally, is it fair to say that that's kind of the goal of an intake, right?
I do that with every client. I have a standard set of questions.
Is that just for the intake or any follow-up?
Any follow-up, I have a basic kind of script, but I always adjust it based on what they're saying.
Okay. But fair to say, once a person gives kind of that history of their background, especially if they've had prior births before, prior experiences with mental health professionals or psychiatric history, that kind of follows the patient as they go through with their subsequent visits.
Yes.
So in this instance, you had some background information from the phone call you had with her, but did you go back through those standard questions that you'd ask in an intake?
I did.
And did you learn a little bit more about about her current mental status? Did you ask her some questions about currently how she was in this November 21st meeting?
I did.
And so, again, do you kind of go through in each and every instance whether the person has any thoughts of suicide or harming themselves or others?
At every visit, those are standard questions that I ask if they have any type of suicidal, homicidal ideation or auditory or visual hallucinations.
Do you ask the same questions each time, or is it kind of fluid based on your rapport and conversation with the patient?
Generally, I try and touch upon the topic. Sometimes we get to that answer indirectly just by the line of questioning that we're using.
Okay. And where it had been reported to you that she had been on the Zoloft and stopped due to insomnia, that she was overwhelmed and her mind was racing, did you talk with her about intrusive thoughts?
I did.
And did she indicate whether at that point she was having any intrusive thoughts of harming herself or her babies?
She was not.
Did she report to you how she was feeling at home with having now 3 children to take care of?
She was feeling overwhelmed.
And that, again, reiterating that around 12 weeks when Patrick went back to work, that she was having increased anxiety.
Correct.
And did she indicate to you that that was something that she had experienced to some extent with her other 2 children?
At least with her second pregnancy.
And was she able to manage that with her second pregnancy without medication?
As far as what I was told, yes.
And fair to say she indicated that she would use breathing, meditation, and yoga to work through it.
Correct.
And so on this November 21st intake date, you again ask about drug use, right?
Correct.
And at this point, she had told you that she did trial one CBD gummy at some point, but that did not help.
Correct.
And you also learn about any prior psychiatric medication she had been on?
Yes, she had been on the Zoloft, the Ativan. She had been prescribed Buspar, but she didn't indicate whether she had taken that or not.
Okay, and so that was her report of her most recent course of treatment, but did she talk about having anxiety issues
yes.
further back in her history?
Yes, in college she had trialed Prozac, Perinatal, and Wellbutrin.
And fair to say she indicated that to you that she did well on those medications in nursing school?
Correct, with the only side effect being sexual side effects.
Did you talk to her at this point in November 21, 2022, about whether she had a plan to go back to work?
I don't know if that was a specific day. I know that we talked about work at a different date.
Okay. If you have your note in front of you, I'd just draw your attention to maybe the last paragraph of the history of present illness.
Oh, I'm sorry. And you're talking about the day of the intake?
Yes, sorry.
Sorry, I thought you said the 22nd. So, yeah, she had planned to go back to work in October, but it got delayed. She pushed it forward to November because she was having anxiety.
Okay. And during the course of this intake, again, you did those same mental status screens for any concerns, right?
Correct.
Did you know any in this face-to-face in-person meeting with her?
No, she was goal-directed, linear. She was a great historian, actively participated in the care plan.
And as far as some of the screenings that you do during these visits, for a person who is in that postpartum period, are there any specific screenings that you do?
Yes, we do the Edinburgh Postnatal Depression Scale. We did the GAD, which is the Generalized Anxiety Depression Scale. We did the Mood Disorders Questionnaire Scale, the Colombian Suicidal Scale, as well as the 5 Ps, which assesses for substance use disorders in pregnancy and postpartum.
And so as far as in each one of those screens, what did you find as it pertained to this particular patient?
She was significantly high in the GAD-7, which is for generalized anxiety. She scored 21 out of 21, which they're just screening, so it's not diagnostic, but it did indicate that she was experiencing extreme anxiety. And then with the Edinburgh Postnatal Depression Scale, she scored a 23 out of 30. But the one that I look for the most in that scale is number 10, and she was negative, and that's for suicidality.
Okay. And so why is it that you look at that one in particular, or why do you consider that most?
Because that shows significant depression, especially if they have thoughts of harming themselves.
Is it fair to say that that Edinburgh scale, it also could fluctuate with a postpartum mom depending on their situation?
Yes.
And the other screens that you performed, did you identify whether there was any substance use issues?
No, there wasn't.
Now, once you were able to kind of gather all this information from her and do these screenings, were you able to come up with an assessment and a plan for how to help her?
Yes,
And what was going to be the plan with Ms. Clancy?
So we had discussed starting Prozac.
Okay. And is that, or why Prozac? Why start there?
Because she'd had a history of being successful on it in the past, and that's a good indicator that instead of trialing multiple medications, to start with the ones that actually work. So I gave her 10 milligrams for the first 4 days to make sure there were no adverse reactions, and then I was going to increase her to 20 milligrams if she tolerated that well.
Okay. And what about some of the medications that she had already, that she was already on, the Ativan and Benadryl and the Trazodone? Did you have a plan for those?
I did. So I encouraged her to take the Ativan. So when Prozac can sometimes be very activating, it can make the anxiety worse before it gets better when you first start it. So I wanted to pair it with the Ativan just in the beginning, just to help her be more comfortable with the anxiety and to make sure that it didn't interfere with her sleep.
And as far as Prozac goes, what class of medication is it?
It's an SSRI, a selective serotonin reuptake inhibitor.
Is it commonly prescribed to treat people with depression?
Yes, it is a first-line treatment.
You said first-line treatment?
Correct.
And the idea of pairing a particular medication like an SSRI with another medication, is that a fairly common practice with psychiatric medications?
Yes.
As far as you mentioned that sometimes symptoms could get worse before they get better. Is that also common with SSRIs?
Yes, it is.
Does it take a while for a medication to get into a person's system and stabilize them?
Generally, side effects are the first week or two, but to get to a therapeutic level, it's about 4 to 6 weeks.
And was this something that you discussed with her about the timetable it would take to reach a therapeutic level?
Yes.
And when we say therapeutic level, what's the goal of reaching therapeutic level?
Is remission in symptoms.
People start to feel better then, right?
Correct.
Now, even though you were advising that she continue with the Ativan and she had told you that she had concerns about continuing with the benzodiazepine, did you indicate that there would be a plan to taper that or reduce that?
Yes, once the activating symptoms went away, then we would look at reducing that and moving away from the Ativan and moving more towards like a Buspar.
Okay. And as far as talking about that plan and what the risks and benefits of that plan were, did she appear to understand and engage in conversation with you about that?
Yes, she verbally understood and said that she understood the instructions.
Did she ask the appropriate questions or follow up?
Yes, she did.